Hey, good morning, everybody. Thank you so much for coming or I guess attending this webinar this morning. I want to make sure and just do a real quick check to ensure that everyone can see my screen. Looks like it's coming through. And let's see here. All right, just going to give it a couple more seconds for people to log in from their previous meeting or after getting some coffee. And then just a reminder, if anybody does have any questions, you can put them in the chat box or the question box. And I hope everyone is safe and healthy and doing well this morning, Wednesday morning, the last day of September. I can't believe it. It's just crazy how quickly time has gone by amidst a pandemic and an epidemic and just everything that everyone's dealing with. So I do hope everyone is well. Okay, well, while people continue to log into the GoToWebinar platform, I'm just going to go over what are commonly referred to as housekeeping items. And one question came in already about will you supply the slides? And I will let the presenters answer that question, but I believe that would be fine. But the entire presentation is being recorded and will be shared along with all of the other presentations that have taken place under the Criminal Justice Behavioral Health Treatment Interface webinar series that the Healthcare Authority started January of this year. So those are all available on YouTube, and I will make sure and share any resources at the conclusion of the webinar today. So, I think mostly everyone is familiar with these various virtual platforms that we use today and rely on today. But in case you aren't, with GoToWebinar, just make sure that if you are logging into your computer and then calling in through your phone, that you do enter the unique audio PIN. And that's to ensure that I'm able to unmute you and you can ask questions freely during the webinar or at the end. If anyone is having any trouble, I will be monitoring my email. If you're having any issues with logging in, feel free to email me at tony.walton@hca.wa.gov. And then don't forget to mute your computer speakers if you're participating by phone as well. And just a quick recap of the webinar controls. This info snapshot shows you where the questions tab is, and then there will also be one that says chat. Feel free to use either one. I'll be monitoring those throughout the webinar. This information shows the audio pane, and then also if you want to minimize the controls, you use this little orange arrow there. Here's the raise and lower hand icon. I noticed that somebody already raised their hand. I went ahead and lowered it because at this point we won't be taking questions. But during the question and answer portion, if anyone has a question, feel free to click on the little hand, and then that will raise it. And then I will call on you and unmute you so that you can ask your question of the presenters. So today and throughout this year with the interface webinar series, we've been addressing various components along the sequential intercept model. And even back in January when the webinar was kicked off, we had policy research associates come and present on the sequential intercept model. And if anyone is interested in that webinar recording or more information about the sequential intercept model, feel free to email me. I'd be more than happy to connect you with some resources. Today, we're going to be focusing on Intercept 4, which is both prison entry and jail reentry, as well as Intercept 5, which is community corrections. And as you notice, there is some back and forth between those two. So without any further ado, I guess we'll get started with the presentation. And I am so happy to have Alexander Stoker and Angela Sauer from both the Healthcare Authority, Division of Behavioral Health and Recovery, and Department of Corrections, presenting today on the Offender Reentry Community Safety Program, or commonly known as the acronym ORCS. So I'm excited to hear more about the program, and just to let you know, I checked with the presenters, and if you have any questions throughout, feel free to ask any questions that come up, and then we can address those immediately, especially if it has to deal with anything that's being currently presented on the screen. Before I pass the controls over, I did notice one more question coming in. Oh, and it's about the slides. Will we get these slides emailed to us? And I think more than likely the answer to that is yes, but let me double check with Alex and Angie and make sure that that's fine, since it is their presentation.
Thanks, Tony. Yes, that is fine. We will have no problem sharing the slides with folks. Right. Before I get going here, I want to make sure everyone can go ahead and see my screen. Am I coming through okay?
Yeah, perfectly. Thank you.
Excellent. Thanks, Tony. I realized that you're really the only person that's able to tell me that, aside from Angie. So my name is Alex Stoker. I am the program specialist that runs the ORCS program through Healthcare Authority. So my primary function is assisting the providers that utilize this program and kind of providing them technical assistance as well as processing their invoices. A little bit about my history. I spent 6 years at a community health agency in Lakewood, Washington. 3 years as a therapist, and then 3 years as a program manager of this particular program in the community. And I'll let Angie do her own introduction here.
Hi, I'm Angie Sauer. I'm the Health Services Reentry Administrator for the Department of Corrections. And I've worked with the ORCS program for about 7 or 8 years and been with the department for a little more than 10 years now. I think that's it.
All righty. As Tony said, as we're going along, if you have questions, please feel free to throw them in the chat box, especially when we get to graphics. Angie is a master at explaining the data behind this, and she'll be happy to answer your questions on my behalf. All right. So a little bit about the ORCS program itself. It's intended to enhance public safety by providing transition planning, mental health treatment, and community support for offenders who are identified as mentally ill or intellectually disabled and who are a risk to the public and or themselves. And it's a collaborative process between the Healthcare Authority and the Department of Corrections. The legislation behind it started in 1999. And it was primarily created to identify a group of individuals who had a very high recidivism rate that appeared to be related to their mental illness rather than any particular acclimation towards committing crimes or those kind of things. They could really see at that time that it was a combination of those two factors. And the way the legislation works is we have two primary RCWs that direct us. First one noted there is around HCA shall contract for case management services and will provide the funds. And that DOC will identify those who are mentally ill and dangerous prior to the release, as well as coordinating a team of representatives to do the transition planning. And it also allows for mental health civil commitment prior to release if necessary. So qualifications for program inclusion, the individual has to currently be in prison when they are evaluated by our committee. And then they need these following criteria. They need a mental disorder, which is defined as what you see on your screen there, an organic mental or emotional disorder which has substantial adverse effects on their individual cognitive and volitional functions. It is typically severe and chronic. So common diagnoses are schizophrenia, schizoaffective, bipolar disorder. Although we do have participants with other disorders like post-traumatic stress, major depression if there is, lifelong history and indication that it severely impacts their functioning. And then it also includes dangerousness. And so that's a danger to self and or others. And we utilize the Washington 1 DOC risk assessment. And the individuals who fall into this category are high violent or high violent property drug crimes, as well as sex offender risk category of moderate, high, or high. And we shifted to the Washington 1 DOC risk assessment so that we would have basically a more standardized assessment of risk. And Angie, correct me if I'm wrong, but I believe we shifted to that about 3 or 4 years ago.
Yeah, I think it was about 3 years ago.
Yeah. And that was just so that when we're going through the committee process, which we'll talk about here in a moment, there wasn't questions around dangerousness from the mental health side, that it was already established by the folks who made it to committee. And then, as I referenced, we have a review committee that determines inclusion based on available mental health records. Basically, we get together twice a month and we review usually 5 to 6 cases, which are usually anywhere from 75 to 200 pages of mental health records, both from DOC and all those mental health providers out in the community. So this is a timeline of the program. It starts with an initial screening by Department of Corrections, which is usually about 12 months to ERD. So what we're looking at here is primarily individuals who are beginning to get identified as having a mental health diagnosis. And so our screening folks in DOC begin to look at that, and then if appropriate, they would send the packet to Angie for review.
Yeah, a question came in that I thought would be good to ask at this time. Somebody asked, what is the makeup of the membership of the review committee?
Oh, excellent question. So the review committee is myself and Angie as state representatives, and then it is a selection of community health providers who are currently providing ORCS program support or have in the past, and are familiar with the program and its requirements. So I think there's usually between 8 and 12 of us, depending on who shows up to the meetings.
Yeah, and every person who is on the committee is an MHP, because the primary decision point for the committee is meeting the mental health criteria for the program.
Great question. So moving on to our second bubble here. Ideally, folks are reviewed and designated by the committee about 9 months to their earned release date, which is their ERD. We oftentimes will have folks that are anywhere from 2 weeks out to their release date to maybe a couple months. Sometimes they're already past their release date. So if we think somebody would qualify for inclusion, we don't avoid their packet just because they're not at that mark. We do try to get folks reviewed if they're appropriate for the program. Once they have been designated into the program, our DOC ORCS transition staff will make the initial contact with the designee. So we have a team of transition coordinators who work with each section in Washington State, and they work with local mental health providers to begin the process of establishing that initial contact, getting some dialogue about where the client's going to live post-release, and just trying to build a little bit of that rapport. Which leads us into the next bubble here, which is where they meet with the designee, ideally in person, and the transition planning begins. So that's about 9 days out from release. And so what we do in that typically is the mental health provider meets with the individual in the prison in person if geographically possible. And that, again, begins to build that rapport so they have a kind of a face with the name, and are able to start to get a feel for who their mental health provider is. And yeah. The multi-systemic team begins meeting, and they try to meet at least 3 times with the designee during the last 3 months of incarceration. It's a minimum of 2 times per RCW, but we aim for 3, again, just because we're trying to build rapport and maximize the success of the individuals releasing. Once they do release, we have an intensive case management services period, which is 1 month following release with the community mental health provider. And ideally, what that would look like is, sorry, I got distracted by the question there. I wanted to answer it, but I see Tony has given a response. Ideally, what that looks like is meeting with the provider several times per week, if needed. So if somebody comes out and they're really stable, they're doing well on their medications, they're probably going to get seen weekly. But if they come out and they're having a little bit of trouble adjusting, most of the programs will try to see them 2 to 3 times per week during that first month, and ensure that they have things like their Social Security taken care of, that their Medicaid benefits have gotten turned on if appropriate. If they have food, clothing, all those kind of basic necessities. So one thing that we haven't really covered yet is that there is a financial component to this program, where each agency that participates gets paid a flat fee per client. And ideally that gets relatively equally split up between the clients. But as all of you know, individuals have individual needs. And so what can happen is you have one individual who maybe doesn't need as much support maybe he just needs a bus pass, help with his phone bill. And then you have other individuals who are coming straight out of prison, and maybe they need first, last, and deposit if they're going to move in somewhere. And so the program funding is able to assist with that. And during this initial month phase, that's when a lot of the expense occurs with things like housing, buying clothing. Often our guys don't have any clothing. They basically come out in their prison attire. Things like phone, bus pass, initial food, all those things are really common expenditures in that first month. As we transition out of that first month, what we're seeing is ongoing communication between DOC, the community provider, and the individual designee in the community. So if they have DOC supervision, which they often do, they're regularly meeting with their community corrections officer and our community mental health provider who's contracted with Healthcare Authority. 90 days post-release, that team that we were talking about, they meet along with the individual and they talk about what's worked well so far and what does the client need more support with. So this is a great 90-day kind of check-in for the individual to say, you know what, I need a little bit more robust help with my making sure I've got my food card and maybe getting my bus pass, a couple days before the end of the month. Little things like that that can allow the individual to kind of air some concerns that they have, as well as review what has been working well. And then finally, 90 days prior to supervision completion, and then 90 days prior to the ORC services completion, there's follow-up with the designee. So the CCO in the first case would follow up with the individual, and then 90 days prior to the ORC services completion, there's significant effort on the part of the providing agency to ensure that the individual knows that the program is coming to an end. Another thing that I have not mentioned yet is this is a 60-month program, so it's 5 years. So during that transition down period, we really try to make sure the individual knows that the funding will be stopping. So I threw a lot of information there about the 5-year life of this program. Are there any questions about that?
Hey, Alex. There aren't any questions specifically about the pathway through the program and the program design. There are a couple other ones that go back to the committee. Somebody asked, why aren't family members represented on the committee?
So I can respond to that. I think that that's a really great question. The whole idea of the committee is that we are making a decision about whether somebody meets the mental health criteria for the program. And so we have mental health professionals that review the person's mental health history. So records from hospitalizations and community mental health and the Department of Corrections mental health. And so we're talking about protected information. And then the decisions that are made are based on a review of those health records to determine whether that mental illness is has a significant impact on the person's ability to function that it's been, you know, a long-term mental illness. And so we want to, so part of that is making sure that we have some confidentiality observed as part of those reviews, because it's health records information. So we have mental health professionals who are part of HCA, DOC, and then community mental health professionals.
Thank you. And a follow-up to that is, do you provide education to the family members?
So yes, I was going to tag on to that since we were so specific in the answer about family members. Whenever available, we involve family members in the release process. So our transition coordinators are really great about reaching out to the designee and asking them, like, who do you have for family support out in your community that you're going to be releasing into? Because as we all know, that is that can be a key component to their success. And so we make sure that they're aware of how the program can help, as well as kind of involve them in that that process of ensuring the success of the individual.
And just to add on to that, the multi-system care planning team that is part of the transition process for the individual who's releasing, that includes the individual, it includes DOC, DOC staff, the community mental health provider, the community corrections officer, any other partners in the community that might be helpful in that person's transition, which does include family. And so those MSCPT teams are part of the legislation, and that talks about how we want to get all of the supports that we possibly can included in those meetings that happen as we develop the transition plans.
Great. For time's sake, to make sure we get to Angie's portion, I'm going to continue moving right along. So if you have questions, we will have a question and answer portion at the end here. Here is our current coverage of Washington State, where we have ORCS contracts available. So if we have an individual who is releasing into one of these counties, we have an identified mental health agency, which you see on your screen here, that will work with them and be able to facilitate the ORCS funding. If they are not in one of these counties, oftentimes what we have happening is an attempt to provide relocation if appropriate. If not, we do have a representative payee that can work with the Department of Corrections officers to facilitate some of that funding. Oh, this is my cue, Angie. We will be releasing an RFP in the future. We're getting requests for more providers for this program. So if you are interested in being a mental health agency that participates in this program in the future, and you happen to be in one of these counties that we do not currently have service in, wonderful. If you happen to be in one of the counties where we do have service in, still wonderful, because we are trying to expand in all areas. So keep an eye out for that in the future. All right, so part of what we do with the individual is make a transition plan. So part one is what we call designee specific. It's things like contacts and emergency numbers, their housing information, transportation plan, what community resources are available to them, kind of initial bullet point treatment plan goals, what they like to do for hobbies or activities, and then what I find to be very useful, a 7-day release calendar. So our transition coordinator helps them identify, like, here's what you're going to do for the first 7 days after release, because that is definitely one of the most vulnerable points post-release. And then finally, medication information. So part 2 of that, and this is all shared with the designee, if that was unclear in my previous statement there. Part 2 of that is who the multi-system care planning team members are, where the housing is, who the housing provider is, excuse me. If there's any state or federal benefit information that needs to be placed, what the plan is for release day transportation. This is a question that gets asked to the individual. What are some signs or symptoms of decompensation when you're not doing well? What should your care planning team be looking for? So typically that's a question that we ask while they're still in the prison and doing relatively well and relatively stable. Any adaptive equipment needs, and then is there any substance use disorder information that we need to be aware of? Is the individual have a particular challenge with methamphetamine or marijuana or any other things that we need to be aware of? And honestly, these guys are pretty good about sharing that information with us. They're usually honestly pretty honest about it. So we talked about the 30-day intensive service period. What we do during that period is we follow a transition plan. We create the establishment of housing and home environment. We meet with the mental health provider on the day of release if possible. We have release funds set up for basic necessities, things like clothing, toiletries, food, bedding, phone, bus pass, and so on. Ideally, on the day of release as well, we start linkages to state and federal resources. So things like DSHS. We get the folks down there for their food card and getting their Medicaid benefits turned on. And then Social Security, this is usually within the first month. If they qualify for some kind of SSI or SSDI, we try to assist them getting down to the Social Security office. Within the first few days of release, if not prior to release, they complete the intake to the mental health agency. One of the great things about this program is that you can get into the prison prior to release and complete the intake and get paid for it because the program has funding that occurs pre-release. Development of the mental health treatment plan. Usually that occurs post-release when they're beginning to meet with their provider. Medication evaluation, ideally within the first 2 weeks of release to ensure that there is no interruption in medication. Connection with any family, social, or agency supports. And then frequent check-ins with community mental health, DOC, and other supports like I talked about. In that first week, we try to see them several times a week and then kind of adjust from there. Ongoing services, so that period, let me take a step back there. So our pre-release period is usually about 3 months, followed by that 30-day intensive service period, which is another month. So for those keeping count at home, that leaves us with 56 months of potential service to follow on. And so that's what we would refer to as the ongoing services period. So things that get continued are mental health services and specialized case management as needed. Housing support is ongoing. And then funding for basic necessities or as needed for a specific resource. The idea behind the program is that we front load a lot of that funding as the individual doesn't have employment or doesn't have Social Security. And then we taper that back over the course of the 60 months. But we can also use, have creative uses of the funding. And I gave this little prompt here for myself and Angie so that we could give some examples. One example of a provider agency creatively using the funding is they had a group specifically for their ORCS release individuals. And so one of the things that they would do is they would have like basically get-togethers. So the ORCS group would go bowling, or they would have like a wings afternoon. Some way to create connection and continue that ongoing support and um, uh, group recovery effectively. Another example, we had an individual who is a level 3 sex offender, and they were having a really hard time finding him permanent housing. And so the program basically designs a plan with him to accumulate money over a period of months by minimizing his use of the funding. And then they purchased a small RV for him. So the limits of this program are really defined by one phrase, and that's, does it support the ongoing mental health and wellness of the individual, and does it support their recovery? That's really the limit of what we have. And so I get calls from providers somewhat infrequently about, hey, can we use the funding for this? And if it meets that core criteria of, does it support their mental health and wellness, and does it support their ongoing recovery? The answer is probably yes. It's really kind of a freeing program as far as the ability to use the funding for a variety of different uses. Angie, did you have any that you wanted to add?
I think the one that comes to mind is there was an individual who was isolating in his housing, and the mental health provider was able to connect with the person and recognize that they were played the guitar, liked to play the guitar. And so they were able to purchase them a guitar, which then allowed for that person to start to have some interactions in the community. That was their way of kind of getting out and being more interactive in their community, and it worked really well for that person. So I think, part of the other piece is that we can really look at, the mental health agencies can really look at what individual needs would benefit that ongoing recovery. So that's one.
Great. So kind of to summarize a lot of the different things I described, but to get them on the page in front of you, there is additional funding to support the needs outside of Medicaid funded services. So things like housing, unfunded medical expenses, transportation, specialized treatment, vocational and educational services, and other unique needs. The benefit of this program is it lowers recidivism for participants. Point blank, we're going to show you some data on that. It's a partnership between Healthcare Authority and the Department of Corrections. And it's additional support for individuals that, frankly, many of you are already serving in your communities. And so it's a great program. And I'm going to just keep rolling right along here so that I can get to Angie's stuff.
All right, so what we have now are just a couple of slides to give you an idea of how many people we have in the program and have had in the program. So the first one is the total number of designations across the years. You'll see that there is a bit of a spike in 2020 with a lower amount in 2019, and basically we had a backlog that we were trying to get through, and we were able to get through that in fiscal year 2020 of individuals, and got kind of up to speed. So one of the things is, I think if we were to even those out, you would see a gradual increase in the number of people that we are designating into the program over time, but we'll see kind of how the next couple of years go. So those are people coming out of prison who were designated into the program. And the next one, so this shows the number of releases that we have. And so again, you'll see in 2019 and 2020, we had an increase of people who were in the program who released from prison into the community, but pretty stable over time too. Okay, next one. So one of the things that we track here is releases by section, and those are the DOC sections of Washington State. So below you'll see the counties that are identified within those sections. And when we started looking at this data, I thought it was really interesting, the increase in section 1 on the east side. Section 1 and 2 are on the east side of the state, and so pretty significant increases in level of participants in the community in Spokane and Yakima areas, and then some pretty much consistency over the other areas. Pierce County and Kitsap County have a higher amount, but somewhere between 18 to 20 are going out to each of the sections, and that's by year. So we added in this slide just for you to gather some more information if you want to know. The Washington State Institute for Public Policy has done ongoing looks at the ORCS program and the cost benefit ratio. The last one was done in December. And then in May of 2019, they did a report on the effectiveness of reentry programs. And the ORCS program had one of the best effect sizes for decrease in recidivism. And so the link for that report, if you're interested in looking at that, what we know, and we're going to talk about recidivism here in a minute, what we know is that people who are engaged in this program have a lower rate of recidivism, and the money that is spent to provide those additional services and the transition with the InReach and meeting those connections is a good model for lowering recidivism, making sure that people have access to services in the community, and then some stabilization in the community. So you can take a look at those reports and get some more information if you'd like. And then I think the last slide is our recidivism rate. So it's a little bit small, but over the course of the 20 years that the program has been in existence, the recidivism rate for individuals who are engaged in the program is much, much lower. Year one recidivism rate is somewhere in the 3% or less, and then a 3-year recidivism typically under about 12%, which is pretty good. I think our current 1-year recidivism rate for the department is somewhere around 11%, and the 3-year recidivism rate is about 30% or 32%, somewhere in that range. So pretty significant impact. And we know that we have the funds available to assist people with housing. We have the InReach of allowing people to get to know who their supports are in the community prior to release. And I think those two things really impact an individual's stability in the community and being able to be successful.
Wow. So much information, so much good work going on. Thank you so much for the presentation and all the information. I'm glad that we have 15 minutes for questions because a lot of them were coming in. So I'm going to go ahead and just kind of jump in. Oh, I guess if you have a question you'd like to ask it live, go ahead and raise your hand. And I'm going to first get to the questions that were entered in the question pane, and then hopefully have enough time for other ones as well. One question came from Donald Benson, and the question was, do you classify by severity? And basically, he wanted to clarify on severity is the classification level for mental health. He's from Georgia and indicated that you have one heck of a good program.
Thank you. The whole intent of the ORCS program was designed to identify individuals who are severely mentally ill and have difficulty with functioning in the community or even in the prison setting, quite frankly. And so when we're designating individuals, we're looking for that group of people who have a more significant mental health, identified mental health diagnosis, and really looking at decompensation patterns and ability to engage in services and those kinds of things. So I think one of the pieces of this particular program is we're really looking at, and if you look at the data, we're really looking at a pretty small population of people. And so identifying who the most severely mentally ill are is part of that, the designation process. Alex, do you have anything to add to that?
Yeah, I would say, I mean, one of our biggest limiting factors is really funding for the program. We can only grow it so much until we get some expanded funding through legislation. That being said, we've never turned somebody away for a funding issue. So when we go through and we're doing the committee, it's based on those criteria that we identified, the severity of the mental illness, and then do they meet the dangerous criteria as defined by DOC.
And then along that same line, from where does the additional funding come from? Grants, or is it all the state funds?
It is 100% state funded.
Thank you. And a couple questions regarding, I better get to this one. She asked it a couple times. Is it required that they are a sex offender, or is that just an allowable criminal history to be admitted to the program?
Correct. It's just an allowable criminal history.
The sex offender designation, we're looking at level 3 sex offenders, and we're looking at those who have been assessed with a risk in high, moderate, or high risk to the community. So again, it needs to be framed in that that risk to themselves or to the community, and that's where we want. So it could be somebody who has a high violent risk level classification, or it could be somebody who is a level 3 sex offender or high risk sex offender.
Thank you. And then some questions came in about qualifications. One was, what kind of qualifications or experience would someone need to either be represented on the committee or to be a provider serving these individuals?
That's a complex question, so I'll try to break it down as much as I can. Typically, committee members are people who are the program managers for one of our provider agencies, because they tend to have a wealth of experience in mental health. They tend to be MHPs, and they tend to have a pretty good grasp on how the program works. And that helps us have fair and impartial committee decisions. To qualify as a provider for this kind of program, ideally it would be a Medicaid community mental health agency. To be honest, though, that would not be a limiting factor if the funding was enough for you to provide appropriate levels of service to the individual. So basically, can you meet the therapeutic needs of the individual? And is the funding that's provided by the healthcare authority enough for you to both pay for those expenses and then the client's medical expenses? So I don't want to rule people out if you're not specifically a community mental health agency, but that's tends to be who we work with.
And along that same kind of question line is somebody indicated how much courage would one need, like a clinician, in working with this population, especially if they're smaller in stature, or knowing that it's this high risk with potentially a violent background. What kind of
I love this question because I used to get asked this question all the time when I was a manager at a community mental health agency. The answer is you're already working with these clients. If this program didn't exist, all these guys would still be on Medicaid. They would still be getting mental health services through a community mental health agency. The people who get identified in this program, most of them, their crisis, their crime occurred within a mental health experience. So oftentimes they were decompensated. Some of the time maybe they were high. The answer is there were very few times when I was working with individuals in this program where I felt unsafe. The majority of the time, they want to work with you because they want to better their life. And there are certainly individuals who will test boundaries and push on that. But I would say that's no different than anybody else that you're working with in the community mental health agency.
Great question. Thank you. All right, great question and great answer. Thank you. Wow, a lot of more questions. I fear that we're not going to be able to get to all these, but we'll see what we can do. And if you have any questions, if you asked a question that was not answered, feel free to email myself or Alex or Angie, and we'll get that response to you. This question comes from Jim Bloss. Most seriously mentally ill individuals have issues with compliance with treatment regimens. In this case, the qualification for the program must bump against the mandate to not hold the individual beyond their release date. How's this conversation go at the release committee's deliberation?
So I'll start, and then Alex, you can add. We work very hard in this program. The transition mental health counselors that are part of the ORCS program, along with the team, work really hard and have the goal that individuals who are in this program release on their earned release date, just like anybody else who might be releasing from prison. We think it's important. There are times when we have to hold people past their earned release date, and that is typically related to not being able to find appropriate and stable housing in the community, or currently right now with the limits on some of the community's mental health contacts, making sure that we have the resources in place with mental health, with medications, all of those pieces before we're releasing that individual. So we work really hard. We do have some people that end up in past their earned release date, but that is also part of the communication of the multi-system team. And so the individual who's designated into the program knows and is aware and is part of that discussion.
I think the only thing I would add to that answer is, you know, it's a 60-month program, and so individuals who might otherwise shy away from mental health treatment often can stay engaged because they have that additional incentive of, I need to participate in my therapy at least once a month to be able to access my funding. And we keep that really broad because our goal is to keep people housed and to keep them stable. And we don't want to force people to go to therapy, but we do require that they have contact with their mental health agency at least once per month. Tony, I saw a really good question from Melody that I want to answer real quick. That's a short one. And the question was, is there a way for a community provider or family member who knows someone currently in prison to get them on the program? And what would the referral process be? They would need to speak with a classification counselor at the prison. And then that person would determine whether or not a referral was appropriate. And then the individual would make the referral that would find its way to Angie.
And you can also, those referrals, especially from the community, can come directly to me as well. And then we can do the screening at this level. We get community referrals often from family members or from providers or from attorneys, all sorts of different things. So that can be done via email to me, and we can take a look too.
I wasn't going to open you up to that, Angie, but I'm glad that you're willing to do that.
Yes, definitely. Yeah, great question, and thank you both. Thank you, Angie, for being willing to take those. With the limited time that we have left, there's a couple of questions I thought were, I guess, poignant and important to address. Can people with substance use disorder be qualified for the program? Most people that have substance use disorder also have serious behavioral health problems.
Yes.
And
very simple, yes.
yeah, no, that's a good one. And then what was the other? Given the likelihood of the individual having great difficulty at release and reentry, wouldn't it be quote unquote prudent to assign a close by at hand navigator involved in assisting in reentry transition, especially those releases who have been in prison so long that they have become institutionalized? Associated question would be, how is the individual prepared for his or her release or reentry?
So the Department of Corrections, as part of the ORCS program, has transition mental health counselors that are in the community. That's where they're based, and they are kind of the lead facilitator of the transition planning process, and they bring together the community mental health, community corrections, the prison staff, and they're the ones who facilitate the multi-system care planning team. So then they follow the individual in the community for the first 90 days after release. So we do have navigators. They're just not called navigators. They're transition staff that assist with from the 3 months pre-release to the community 3 months after release. And then they're also available after that for resources to the mental health agency or to our community corrections officers.
Wow, great answer. Thank you so much. And we have come up against the 9:30 mark, and there are still so many wonderful questions. I would urge you, if you have a question regarding this program or some of the specifics, please feel free to reach out to Alex, Angie, or myself. I'd be more than happy to field those as well. Or more than likely, I'd be asking Angie and Alex for the answer. But regardless, spread the love. Thank you all so much for joining this this month's webinar. We will be talking next month at the end of October about the Community Assister Program through the healthcare and how individuals can get signed up to help people get enrolled in Medicaid. So very important, especially when discussing reentry and accessing services and continuity of care. So thank you so much, Alex and Angie, for your time today, and thank you all for attending. And I did post the handouts in the handouts section, so you can get the PDF version of the slides there. And in the chat box is a link to the YouTube channel where you can find this presentation and others from the Healthcare Authority. I hope everyone has a wonderful day.
Yeah, thank you, everyone.